These next two presentations will touch on culturally informed clinical practices for Asian American and Asian immigrant mental health. And so our next speaker is Christina Yu. She's a clinical supervisor at the Korean Community Center of the East Bay, KCCEB. She facilitates clinical competency of the MSW and MFT associates and interns and provides mental health services under the Asian Community Wellness Program. She is a licensed clinical social worker and has received her MSW from UC Berkeley. With 15 years of experience, Christina's trauma-informed work began in the medical field, supporting patients and families facing chronic and terminal health conditions, mild to severe disabilities, palliative care, and hospice care. And so she's worked more than 12 years as a case manager in Alameda County, providing services to a diverse population who face traumas from exploitation, homelessness, community violence, rape, intimate partner violence, complex health conditions, and food insecurity, legal system, unemployment, poverty, institutional and systemic racism, and immigration. And so Christina was born and raised in Oakland by a family that immigrated from Toisan, China, and she speaks conversational Cantonese and is skilled in EMDR, DBT, trauma-focused CBT, crisis intervention, motivation, interviewing, risk assessments, and social services. And she utilizes trauma-informed lenses to serve others and is passionate about the holistic treatment that supports overall well-being and empowerment of individuals and community. And so with that, please join me in welcoming Christina.
All right, hi everyone. I hope everyone had a good lunch. As Ella mentioned, I am Christina Yu. I'm a licensed clinical social worker at KCCEB. So I just want to preface this that I know we use the acronym AAAI in this workshop. Sometimes what slips out is that I also include refugees, because when I do this training, which is 2-hour training, and I'm condensing that into 20 minutes today, that naturally that just kind of comes out. So I just want to be inclusive that usually is the population that we also work with at KCCEB. So a little bit about KCCEB. KCCEB, we were founded in 1977. We strive to empower Korean American and other immigrant refugee communities in the Bay Area through access to education, services, resources, and advocacy. So we, at KCCEB, we provide culturally sensitive one-stop service to over 10,000 persons annually across 5 Asian languages. Services include healthcare, social services enrollment, mental health, legal services, leadership development, wellness, and community programs. Our vision is to provide wraparound services to immigrants and refugees, encourage innovative change, and advocate for immigrant refugee health. So one of the programs that we have at KCCB is that we have the Asian Community Wellness Program, where we provide mental health early prevention and early intervention services for the East Asian community. And our goal is to bridge the gap to be a welcoming space to support our mental health wellness in our community. So when we work with our community, we're looking at usually 2 different models, right? We're looking at the individualistic and the collectivist model when we're serving our community. And so these are the 2 values. When it comes to the individualistic model, this falls under the Western value of mental health. In terms of, I am responsible for my own mental health and recovery. I need to find ways to cope, manage, and heal. And how do I find personal meaning and fulfillment and self-actualization? And then when it comes to the collectivist model, we're looking at Eastern values. And that falls under, my mental health impacts and is impacted by community and society. And also, how do I heal in the context of my community? How do I belong and how do I find value and meaning again within my community? So at KCCEB, we have a culturally responsive care model that we utilize. We use the acronym RIPE. The RIPE model is what we use to design our programs around. And so in the next few slides, I'm going to go over in detail what these various areas are. So the RIPE model stands for responsiveness, innovation, participation, and empowerment. So this model utilizes, we want to make sure that we meet our clients where they are at. So I will go into the next one. So under responsiveness, meeting where people at. The first key to responsiveness when we're meeting our clients where they're at is to find out what is it that they need. And what we have found that rather than beginning where our clients' emotional needs are and what the mental health needs are, is that it's actually easier for us to start building that relationship by meeting their basic needs, meeting their basic and concrete needs. And so usually those concrete needs may mean access to social services, access to healthcare, maybe language access, maybe access to education. And so I just want to also note that, coming from a historical and cultural context, we know that in our Asian community that mental health is, addressing mental health is still a stigma. And that our folks will not necessarily come to us readily wanting to talk about their emotional and mental well-being. And that maybe that's because it's not something that we do in our family, or that's not what we do in our community. It's still, and because that happens, there's no, maybe there's difficulty in defining what is it that they feel, or even there's the communication skills is not there. And so some of our clients who come to us, they know what is it exactly that they need, right? That they come to us saying that they need specifically the healthcare, education, and access to social services. But then there are also times where they're not sure of what is it exactly that they need. And some of the work that we do is that we want to help define what the needs are in our community. And that would mean that we would have to conduct surveys, right? One of the surveys that we conducted was a wellness survey to find out what's going on in our community, what are some needs that are out there, and what are they dealing with right now, and what is their sense of well-being. One of the other surveys that we conducted in response to the recent AAAI hate and violence is the community safety survey, is to find out what is our community's sense of safety at this point. What is their experience with violence in the community? And that helps us identify, what kind of resources we might want to make sure that we have available to our clients in our community, but also where can we also refer them out to in terms of our connection and network. Under responsiveness, building trust. So when we are building trust with our clients, it is important that we have, I think it was mentioned earlier before that we have representation in our community in terms of providers, right? That language is important. And when we provide practical and concrete needs to our community, to our clients who make that their priority, this is a way where we can start our relationship with them, is that they find that they can rely on us as providers, right? When we provide them with those practical, concrete needs, or that in that time that we connect them to what is it that they need, that they can start feeling comfortable with us, and that's when they start to share their stories. And that's how trust is built, where they find that we are trustworthy. And that if we are trustworthy and they trust what we have to say, that when we start inviting counseling into the conversation, that there would be more openness to that as well. And I want to also note that we want to rethink how we provide counseling and where that takes place. Sometimes counseling happens in waiting rooms at social services offices. Sometimes counseling happens on the car ride to the appointment together, right? And when we're thinking about from a trauma-informed standpoint, when we're thinking about that lens, we want to be flexible and we want to rethink where counseling takes place. So for example, if let's say someone has trauma behind, maybe in confined spaces, that maybe your sessions are going to occur outside. Or that for those who are restless or agitated, that maybe your counseling session occurs during a walk, right? So we want to think about that and be flexible in how we think about how we serve our clients. So innovation. Innovation. So cultural responsiveness is foundational. So when we talk about innovation, we are combining community-defined practices and holistic healing into mental health concepts, which is evidence-based, right? And I want to acknowledge that at the mental health field, the textbooks, the academia, our degrees, it's all based on Western concepts, and it's based on Eurocentric ideas, right? And they're not necessarily going to be applicable to our AAI communities. And even like the idea of the DSM, right? The DSM contains a Eurocentric, definitions of what is considered maladaptive or what's abnormal behavior. And I know that in our field, the reality is that we do utilize the DSM. So before you come in and attack me, that we utilize this for categorization, billing services. This is how we justify our services, right? But I want everyone to just think about how when we're doing assessments, when we're working with our communities and our clients, is that when we're doing assessment, we want to do that under a cultural context. What is normal behavior within the context of culture? And I also want to note that, keep in mind that when we impose, Western views, it can also be re-traumatizing to some of our AAAI folks that, for immigrants and refugees who are during their acculturation process, that there's an experience of loss and disconnection from culture. And especially for those who may have come from countries where there's a long history of colonization. So how do we connect to our AAI clients, right? We want to provide counselors who are relatable, who understand the challenges and the backgrounds our clients come from, who can speak their language. This is what builds trust. Offer the ability for clients to go into deeper therapeutic alliance, allow them to go into deeper emotions and beliefs without having, while being able to convey it in a more nuanced way. I don't know how many people here who have parents who, when they lecture or they tell you something, they're using a lot of idioms or a lot of, old traditional, teachings, right? And so I currently have, one of my clinicians who utilized some of that and has been able to incorporate that because that's a form of expression. However, at our agency, we want to use this cultural practices to deepen our mental health work. So following under innovation, bridging cultural practices with mental health concepts. When we talk about culturally responsive care, it means that assessments include exploration of individual culture, traditions, and norms. And to do that, we look to clients as the experts. What do they do at home? What are their practices, their beliefs, traditions, and norms? For example, in Tibetan culture, it's encouraged and highly regarded to talk about death. But to the Western, idea of, that falls under mental health, that could be a risk that we want to further assess, right? But does that mean that this person is displaying SI? Taking into consideration that in our culture, the idea of spirituality, superstitions, spiritual guardians, seeing ancestors, dreams have also important relevance, right? What is it that we see in dreams? And what we actually see in external stimuli. Sometimes the trauma response could mean seeing shadows too. So, when we are doing our assessment before we automatically assume psychosis, we want to explore a bit more. What is it relevant and what is the significance of these things within the context of their culture? And one of the big questions that I've learned to consider here is that, are these signs, are they risk factors or are they protective factors? When someone is seeing their ancestors, is this ancestor guiding them through healing? Looking at family systems and dynamics, right? I think that many of you who have been supporting the API or AAI communities, that we understand that there's a collectivism within the culture, that the family operates as a unit, that what happens to me happens to my family, and vice versa. This is what's harmony. This is what's maintained in the home. It's part of the culture. But according to Western view, it could be seen as enmeshment. Or if we make decisions to benefit our family or the greater community, it can also be defined as people-pleasing, right? So we want to, again, understand our clients and our family under the context of culture and what their values are. And sometimes in our AAI communities and our families, drawing boundaries is not even a possible thing. So I'm going to jump into interventions and healing because I want to be mindful of time. Intervention and healing. So under this, we kind of talked about meeting concrete needs, meeting practical needs as an intervention. And as a way to build relationship and build trust with our clients. But I included that here because I want us to reframe why is it that we provide concrete needs and what purpose, right? We included this under an intervention because we want to remember that when we are meeting concrete needs and practical needs for our families and our clients, we are addressing mental health, that we're alleviating anxiety, stress, depression, right? Sense of hopelessness or helplessness, right? And then in that work, we could be instilling hope and empowerment. And then connection to community, building connections, right? Connecting to community and ancestral roots. Familiarity with language, food, smells, activities, right? Those are the things that can strengthen ethnic identities and provide sense of belonging and connection to home and family. And so I want to bring up the example, and so some of our subcultures, some of our families come from rural areas in Asia. And those rural areas, farming was a big part of life. And community gardens here in the States can be a very healing activity. Growing your own vegetables, being in touch with land, that's a very healing activity for those who come from those areas in Asia. And we also know that the data shows that, sense of connection is very much tied to overall sense of well-being. Food as wellness, right? Food in our culture is not just central to holidays and family gatherings. Oftentimes, food is connected to our overall wellness, right? For example, in Chinese culture, emotions are tied to certain organs, right? And how often is it that we hear our parents say that they have to eat certain foods to support the well-being of that organ or your overall well-being? Mind-body practices. Mind-body practices. So, an example of that, in Chinese culture, negative emotions can disrupt the body's energy system. That is the qi. But what are some of the things that resonates with our community in terms of how do we rebalance our qi, right? We do activities such as Tai Chi, Hua, Qigong, tapping of the meridians, right? Acupressure. Those are the various ways that we deal with healing. Yoga, right? Yoga is another type of mind-body practice, and also somatic work. Your next speaker, Dr. Chang, is going to talk more about how she incorporates somatic work into her practice. Glazing down to storytelling. Storytelling, aka narrative therapy, right? Space to share with community. It gives voice when we have been ignored or felt invisible. It provides space for clients to take ownership of stories, and that's empowerment. And lastly, I want to also mention bringing in traditional healers that our clients trust. Oftentimes, these healers in the community are probably going to be much more important than us as the mental health providers. This is part of their strength, this is part of their culture, right? And so, for example, in Hmong culture, there's a heavy reliance on shamans, and that even if they engage in Western treatment, that they bring in their shaman with them because a shaman is someone who is extremely important to their healing. Or that even in Cambodian culture, that one of their resources is bringing in and chanting with Buddhist monks. That chanting is a way of healing. It's meditative. It's a way of cleansing and addressing your stress. So then the last two areas of the right model are participation and empowerment. We approach from the perspective that our clients are the expert of their lives. We give them power, right? The AAAI experience often includes loss, erasure, oppression, and being other. And all of this can be internalized. So when we honor culture, ethnic, linguistic, and religious backgrounds, we embrace them as a whole, especially for the parts that they were hate targeted for. I also want to note that the power imbalances between client and ourselves as professionals too. That as professionals, sometimes we can be seen as the authority figure, and that in Asian culture, sometimes the authority figure is not to be challenged. So, when we're working with our AAI clients, we want to make sure that we kind of even out the power balance and make sure that we take efforts to collaborate, right? This is part of our value as mental health clinicians, that we collaborate with our clients to come to agreeable goals. Honoring resilience. Our clients who have experienced trauma are survivors, right? We want to support them in self-advocacy. So teaching them how to access resources, teaching them how to ask for help, this is empowering, right? Helping them seek opportunities where they can also lead in their own communities too. That can also be part of their healing process. And lastly, I want to close with one of the programs that we have at KCCEB using the right model. One of the things that we created in response to the most recent AAPI hate is that we created the Senior Street Smart Safety Program. For some of our seniors who have experienced violence in the community and have felt unsafe joining the activities that they are accustomed to, we developed this program that is a 6 to 8 week program. It's a workshop that's led by a counselor. And it has two purposes. So one, it provides practical skills, training to our seniors to keep them safe, to build their confidence. So some of those skills could be posture. How do you walk in the community? How is it that how do you respond? What do you carry and what do you not carry in your pockets, right? Those are very practical things, tangible things that they can hang on to. And also how to report a crime, and also why. Why is a big one. Because we also want them to acknowledge and also understand that when we're reporting crimes, it's not just about them, it's also about having the data for the broader community, right? And the second purpose is providing space for seniors to share their stories and support each other and lift each other's stories and experiences so that they can advocate for local change. So in this space where they are learning in this classroom that, that there's this, that they eventually start sharing their stories with each other and they start supporting each other. And so this program was designed to for the purpose of just making sure that, we are supporting our seniors who have experienced violence in building more confidence and rebuilding their sense of safety out in the community so they can participate in the activities that they were engaged in prior, so that that's to just lessen their fear. And that's it. So I'm gonna